We literally have just 5 minutes, so I'm going to just highlight certain areas that might help us with this afternoon's discussions, particularly at the debate. A good question there was, should we be operating on patients with, who are asymptomatic with severe regurgitation? Well, the data is very compelling for the mitral valve. We know that patients will live longer if they get a mitral valve repair than compared to patients who get a replacement, and they'll have better preservation of function. However, the data is still not there for us to do the analogous treatment option for a patient with aortic regurgitation. In the end, we have, of course, good replacement options, either the Perimount or the Hancock 2, but the problem is structural valve deterioration. And one of our problems is that most of the prostheses, as you can see here, are put into patients who are over 60 years of age. We expect them to do well. They won't have problems with bleeding because we don't need warfarin. And of course, provided they're over 70, the incidence of structural valve deterioration is very low. But if they're over 60, we begin to see a fall off. In other words, the actuarial freedom from valve structural deterioration begins to fall off after 5 to 6 years. So we must be very careful in younger patients. They are good valves. Freedom from endocarditis is a problem, though, and thromboembolism compared to an aortic repair. So what are the choices of procedure? Well, as I see it, there are 3 levels of choices. Number 1, are we going to repair an aortic valve, or are we going to replace this rigor? Second order of choice is what leaflet repair technique are we going to use? And then the third level of choice, if you want, is do we repair the aortic root itself? Should that be part of the operation? So these influencing factors I've tried to summarize in this slide. A little busy, I apologize. Well, age is clearly an influencing factor, and we'll talk about that shortly, as would valve type and valve pathology. Along with that, the associated aortic root pathology would be important. Age, of course, for patients who are over 60, the attraction of a valve repair diminishes with the risk of a biomechanical structural deterioration decreases, because the 5 to 10 year freedom from reoperation after repair may be acceptable for younger patients due to lack of an alternative, but that, of course, would be unacceptable for an older patient. I see. Do you want me to go ahead and stop there? Or?
I think we'll have to switch because we're forced to at this stage, Mark.
Yeah.
Yeah,
perhaps we'll finish off the rest of this talk as part of the next session, because the lunchbox sessions are going to start hopefully on time here.
Right,
so we'll cut it prematurely there.
Thank you for being so accommodating, Mark. Thank you very much.
I'll hand over to Mark for him to finish off from this morning.
Thanks, Mike. So just to recap on some of the influencing factors that would affect the choice. Remember I said the choices that we make is valve repair versus replacement. Then we have to decide if we're going for repair, how do we repair? In other words, what kind of leaflet repair technique are we going to use? And then the third choice, as I see it, is do we remodel or reimplant the ventricular aortic junction, in other words, the functional aortic valve. And so they're the 3 choices as I see it. The determining factors or influencing factors include age, the valve type, the valve pathology, and the associated root pathology, and I explain those subsequently. Associated intracardiac defects, particularly in younger patients that we have to deal with. The presence of a connective tissue disorder, infective endocarditis versus rheumatic disease. I think the surgeon's experience is important as a determining factor. Of course, patient's choice, whether there's an actual contraindication or an unwillingness to take anticoagulation. And I do think residual aortic regurgitation after the repair presents a dilemma. In other words, another factor determining a choice of whether to give up on the repair and to proceed with replacement. I purposely left out ventricular function and future expectation because I don't believe we are in a situation where we are with mitral valve surgery today, where we might go for a less than perfect repair, knowing that ventricular function is more than likely to be preserved with repair rather than a replacement. I don't feel we have enough compelling evidence to be in that position with aortic valve repair. So as I said, for age, just a comment, For patients over 60, for example, the attraction of a valve repair perhaps diminishes as the risk of a biomechanical structural deterioration decreases. And I also pointed out the 5 to 10 year freedom from reop after repair may be acceptable for younger patients because there's a lack of an alternative, but that might be unacceptable for an older patient where aortic valve replacement is still a decent option. Does the valve type? In other words, bicuspid versus tricuspid. I haven't introduced any other quadricuspid or unicuspid valve, but let's stick with what we see commonly. The answer to that probably is best illustrated by Hans Schaeffer's in Hamburg, who has shown us that the freedom from recurrent aortic regurgitation is roughly the same for a tricuspid versus a bicuspid valve. And that's with a very large number of patients over many years. So we can safely say it really shouldn't influence our choice. Again, freedom from valve replacement, the same, although it has to be said that there is a significant difference in the freedom from reoperation. In other words, if we're repairing a bicuspid valve, it is fair to say we're more likely to be back for a reop, but that may involve still avoiding a biomechanical valve or a mechanical valve, and that would be acceptable in a younger age group. And remember, freedom from all valve-related complications, no major difference between tricuspid and bicuspid. Valve pathology. Should 1 or 2 or even 3 leaflet involvement influence or determine what we do? Should the requirement for multiple leaflet repair to influence it? And what do we do with their calcifications? Well, let's look at that. And Dr. El-Khoury will recognize this slide. We can safely say that whether we use a plication technique for cusp prolapse or a PTFE resuspension, or either, at least in Belgium, I think it's fair to say that it makes no difference. In other words, we can expect excellent freedom from reoperation with any of those techniques. So it doesn't really matter where we use a complicated repair for a leaflet or a less complicated, we expect good results. And freedom from a significant regurg, excuse the spelling there, again, depending on no matter how complex the procedure becomes, it seems reasonable to go ahead with repair. However, things are a little different when it comes to pericardial patches, and I'll go over that in the next talk where I'll give the scenarios where a pericardial patch may be useful. It is fair to say there is a significantly higher failure rate, if you want to call it that, when we have to use a pericardial patch. So when we introduce complexity in the form of a pericardial patch, it is fair to say the attraction perhaps for repair decreases. I think it's fair to say that in general, if it's a simple repair, for example, and I'll come to this in the next talk, such as a pericardial patch for a leaflet perforation and endocarditis, that's clearly preferable to a bioprosthetic or a prosthetic valve. And in connective tissue disorders, this does influence choice. I think that in general, we were looking at a different scenario perhaps nowadays with the availability of scanning, and we tend to be operating in connective tissue disorders in the main for dilating aortic roots with pretty decent valve function. It's rare that we'll have somebody with severe aortic incompetence occasionally, but in the elective setting, not the case. So that if it's Marfan's, Loeys-Dietz, Turner's syndrome, or if it's Ehlers-Danlos 4 subgroup 3 or something like that, or whether we've got bicuspid aortopathy, or indeed the familial thoracic aortic aneurysm syndrome, these will not push us towards replacement anymore. I think a valve-sparing route has been demonstrated as the best option. I think the surgeon's experience is very important. There is a learning curve, and there's no doubt about it, and there is a little bit more than just being good at repair or teaching yourself to be good at repair. Also, a surgeon is important. For example, if you're pretty au fait with doing a Ross procedure, perhaps you'll be a little bit more inclined to aim for a replacement in the form of an autograft than if you're not trained to do a Ross procedure. Again, if you do a lot of aortic root surgery, you'll be more inclined to do repairs, because a leaflet repair is very straightforward. Perhaps the root repair is a little bit more involved, and it depends therefore on the surgeons, not only how often you've done a repair, but I think what range of options he feels comfortable or she feels comfortable offering the patient. And Hans Schaefer's data shows us that you can see from depending on the year, his best results were the most recent results. So from 2003 to 2007 is far better than things were from 95 to 98. So experience does matter. And patient preference. Obviously, in our we've been talking a lot about guidelines. We are now expected to allow the patient to contribute to their choice in the guidelines, as it were. So anticoagulation and lifestyle, I think, could have an important part to play. You might aim to do a repair rather than a replacement for that reason. And some patients, on the other hand, have a concern about future reintervention and may feel, rightly or wrongly, they just don't want to repair because there is an element of uncertainty about it, and the likelihood is that future reintervention may go for a valve replacement. As for associated intracardiac defects, the two that bother me as a congenital surgeon would be subaortic membrane and VSDs. When we repair these, our valve repairs are not don't achieve the same longevity as we'd see for an aortic or tricuspid valve repair, say for prolapse. I think that's because the subaortic membrane, if we resect the membrane, we're often removing the membrane from one or two, sometimes all leaflets of the aortic valve. We tend to leave an aortic valve a little bit roughened up and so on, and I think that recurrent aortic incompetence early, within 5 years, is not that unusual, especially when there's established AI with the subaortic membrane. And the same for prolapse of a leaflet with a ventricular septal defect. We like to think that we will close the defect and expect that valve to be repaired and that repair to maintain, but the data does not support that. And in fact, closing the VSD in a patient with established aortic incompetence, it's a hard valve to fix. It's unpredictable. And I've had several patients myself who've ended up in getting a Ross procedure after a failed valve repair. In this slide, what we're trying to understand are what are the univariate predictors of reoperation or recurrent regurgitation, and this is just to support what I was explaining, that VSD is a classic example of an associated intracardiac defect that's associated with early failure. The other point I would like to make, and I've mentioned it, alluded to previously, it's not good enough to say we have a very good valve repair until we're well on 5 years. Many repairs will seem to be intact, or the patients will tolerate progressive aortic incompetence, but beyond 5 years we start to lose what were good results, and to keep that in mind. So don't, if you're reading literature, reading the data from centres and you want to look at repair techniques, make sure you're looking at 10-year data rather than 5-year data. The other choice that I mentioned is, do you repair the aortic root? Well, if the aortic root diameter is greater than 4.5 or the aortic cross-sectional area over height ratio is somewhere between 8 and 10, it's an easy choice. Where it becomes a more difficult choice is, of course, where it's less than that, and do we need to reinforce the ventricular aortic junction with a root repair or in the form of a remodeling procedure or a reimplantation procedure? And here we see, and we'll be discussing these a little bit later, and I'll leave that to Dr. Khoury, who will show us some of these a little bit later on. But there's a remodeling, and there's the valsalva reimplantation technique, or it could even use the Stanford Modified 5 technique. So there are many of those available to us. But what we do know, no matter which one we use, that the freedom from reoperation is better when we use a root replacement compared to not using a root replacement. So I think there's compelling arguments for going that little bit further with the operation. And we know that root replacement, for example, is better than a subcommissural annuloplasty. Again, Dr. El-Khoury's data. So, root replacements, remodeling versus reimplantation. This is another choice we have to make as repair surgeons. Well, what can we say about one versus the other? Well, we know that bypass and cross-clamp times will be longer with reimplantation, and you'll see some of this during the wet lab demonstration. Early mortality is comparable between the two techniques. The freedom from moderate to severe regurg, say 12 years, on meta-analysis shows that there is little or no difference between them, and the freedom from reoperation at 12 years shows little or no difference between the two. So how are we going to make a choice? Well, this is my own feeling, and it may not be the feeling of everybody, but we can discuss it. My preference is for remodeling when we have a non-dilated aortic root, with, say, a bicuspid valve sparing procedure, where the coronaries haven't migrated. And sometimes using a reimplantation, say with a Vascutech valsalva graft, can get you into a little difficulty because the coronary anastomoses are more difficult in that case where there hasn't been a dilation and a coronary migration. My own preference is for reimplantation in Marfan syndrome connective tissue disorders and those that are associated with excessive annular dilatation, because we may not be supporting the ventricular aortic junction with the remodeling technique unless we add in a Lancet ring or some other means of stabilizing the ventricular aortic junction. And the final thing is residual aortic regurgitation and repair. Well, we know, I think the answer to that is quite simple. Try not to have any leak at all at the end of a repair, because if you do, at the end, you will be back. That's the one take-home message from Dr. DePaulus's data, which showed us excellent freedom from residual significant AI with his DePaulus graft, but not so good if there is residual AI at the time of reimplantation. In fact, within 5 years, you're back.